The following podcast is part of a certified educational activity titled Individualizing Prostate Cancer Management, employing evidence-based strategies to impact community care across the disease continuum. Access the entire activity and complete the post-test at peerview.com/WQG860. Downloadable slides and practice aids are also available.
Hi, everyone. Good evening. Thank you so much for joining us to talk about prostate cancer this evening. For those of you who are still getting your dinner, don't worry, you're not late. We're just getting started. And for everyone online, welcome and thank you for being here. We're going to talk about individualizing prostate cancer management and employing evidence-based strategies to impact community care across the disease spectrum. So welcome. My name is Alicia Morgans. I'm a GU medical oncologist, and I am the chair of tonight's program. But we also have the wonderful Matthew Smith and Sandy Srivanas, who are joining us to come here to talk about prostate cancer with you tonight. Our goals for today are to augment your knowledge of the rationale and efficacy data supporting approved and emerging prostate cancer treatments, to equip you with the strategies to create individualized treatment plans incorporating modern treatments for patients across prostate cancer disease stages, and provide guidance on team-based strategies to proactively mitigate and manage adverse events associated with our contemporary therapeutic regimens for patients with prostate cancer. So 3 lofty goals. I think we can accomplish them all this evening. You know, as we consider people with prostate cancer, I think we recognize that there are unmet needs. We have multiple therapeutic advances in this space, including in the high-risk localized prostate cancer space, as well as metastatic hormone-sensitive disease and metastatic castration-resistant disease. But there's still a lack of really having the procedures that we need to effectively implement these all in practice. And of course, we do need new therapies as well. How can we improve effective decision-making and optimize patient care to really maximize the treatments that we have available for us today? I think there are many factors that do contribute to our treatment decisions. And I also would say that I think I am, and I know my colleagues are advocates of a shared decision-making approach that considers the patient preferences as we think about this and really tries to work together with patients and families to make these treatment choices. Some of the factors that we have to consider, of course, are the cancer itself, the extent of the disease, de novo or recurrent status, if we're talking about metastatic hormone-sensitive disease, prior treatments like radiation or a prostatectomy perhaps, or no prior treatment, molecular features. The patient also comes into consideration, of course, the patient's overall life expectancy, their comorbid medical illnesses, their concomitant medications, drug-drug interaction potentials, their performance status, their symptoms, their social supports, their social needs perhaps, the things that they need to do to support their family as well as their preferences and their beliefs about treatments and their wishes going forward. I think each clinician recognizes or should recognize that we all also have our own biases and preferences. We all have a certain amount of experience with different treatments, and I think we develop preferences based on our experience, our comforts, our workflows, our teams. We also have comfort with adverse event management and confidence in our ability to take care of different adverse events as they come up, which also absolutely influences the treatments that we may choose in our clinic, as well as our interpretation of clinical trial data and our own preferences and beliefs. Finally, the treatments themselves all have their own potential side effects, their schedules, their monitoring, the cost to the patient, as well as their cost to the group that's delivering them, the expected efficacy and toxicities, as well as the availability, which for some drugs more than others may affect our treatment choices. It's interesting. I've had some conversations looking at some newer data that's come out from ESMO about drugs that are widely available, but some practices no longer have access to some of the drugs or never had access to some of the drugs that are now potentially used in these settings because they just don't have the workflows in place. And geographic barriers and other things may also limit us. So there are certainly considerations around treatment themselves that we have to be aware of. So when we think about shared decision making, I think it's something that we need to consider. And ZERO is a prostate cancer advocacy organization that advocates also for shared decision making, for empowering patients to have the information that they need to really engage in these decisions and discussions. It can be difficult to implement shared decision making in clinical practice, certainly because of time restraints, because of comfort of clinicians, because of patients' health literacy, numeracy perhaps, or even their willingness or confidence to engage, but it is something that we can help support in our clinical practices through making ourselves available, through making our clinical teams available, and trying to ensure that people understand the treatments that we're offering in a way that makes sense to them. As we can see, common barriers include limited appointment times and poor health literacy, and ZERO does try to overcome that with some plain language information that's been written specifically for people of different educational backgrounds and experiences to really understand and engage. And these educational materials can help the physician team, the clinician team really communicate in a short period of time and give some information for patients to take home and review later. So let's move now into our next section. I will be talking about this section, and then you'll get to hear from my colleagues who I'm sure will be very interesting as well. So let's talk about high-risk non-metastatic castration-resistant prostate cancer and really talk about localized prostate cancer recurrence here as well. So let's define high-risk localized and locally advanced disease first. As you can see in this figure on the upper left, a majority of the patients that we see actually diagnosed with localized prostate cancer. And we can see that there's actually quite a split between patients with high-risk disease, intermediate-risk disease, and low-risk disease. And those at high-risk disease, of course, are at higher chance of having recurrence, with a much lower proportion of our patients being diagnosed with regional or distant disease. We know that those patients who have that high-risk disease have a higher risk of biochemical recurrence, metastasis, and death from prostate cancer. And ultimately, 20 to 40% of our patients with high-risk localized disease who get either a radical prostatectomy or radiation therapy with intent to cure their cancer will develop biochemical recurrence. Down at the bottom is a table where we can see those factors that are associated with increased mortality among people who have high-risk prostate cancer. You can see these features are probably what we would expect: a higher PSA greater than 20, a Gleason score that's in that high-risk category of 8 or greater, clinical T3 disease or higher, or just that constellation comprising high-risk disease by NCCN. So we certainly have unmet needs in localized disease. Despite the progress in many areas, we find that within 10 years following that definitive therapy with intent to cure, 20 to 50% of patients will experience disease recurrence and have a rising PSA. And there has been limited level 1 clinical evidence to really treat patients who develop what we call biochemical recurrence, which of course is a measurable PSA in the setting of radiographic studies like CTs and bone scans or MRIs that do not have evidence of metastatic disease radiographically. So patients with high-risk BCR are at an increased risk of prostate cancer-specific mortality. And high-risk BCR, I think, is a population that is certainly of interest to us. So how do we define high-risk BCR? One of the ways we do this is to think through PSA doubling time. And to tie this in with ASCO GU 2025, of course, we're all here right now. Our team had a presentation, just a poster earlier yesterday, where we investigated this PSA doubling time concept, because high-risk BCR, certainly at least in clinical practice, is often defined by a PSA doubling time of 9 or 10 months. And in the studies that have been done to really identify this population, that identifies a group with this short PSA doubling time who is at higher risk of dying from prostate cancer. In this analysis, which was a real-world study looking back at charts that physicians kind of curated for our team, we found that a majority of patients didn't actually have a reported PSA doubling time within those charts. And among those patients who did have reported PSA doubling times, they were often overestimated, which means that when we looked at the traditional calculators, they were longer than the traditional calculator actually said that they should be. So people are underestimating the aggressiveness of the prostate cancer. We also found that for those patients who had a PSA doubling time versus those that did not recorded, those that had a PSA doubling time recorded were more likely to undergo treatment intensification. as was appropriate for that PSA doubling time and perhaps for the clinical situation. So really interesting that we're not necessarily calculating this at a minimum. We're not necessarily as clinicians recording this information in our charts, and perhaps something that we could do more frequently. In any event, there have been multiple phase 3 clinical trials in localized disease that are ongoing and that will help inform how we treat patients in this disease setting with high-risk localized disease. You can see just a number of them here. The Proteus trial, which is looking at patients who are undergoing prostatectomy, and ZERAD, which is looking at patients undergoing radiation, Atlas, also radiation, and DASL-HiCaP for radiation. So really interesting that we're doing these studies, and hopefully we'll have some more information shortly. Embark and ARISTEP are two studies, Embark having reported out already, ARISTEP ongoing, that are looking at a biochemically recurrent population. So we'll learn more information to inform that as well. And Embark, of course, as we know, has led to approval of enzalutamide in this setting. So let's talk through some of these. The phase 3 Proteus trial is a study that is looking at a prostatectomy population, and all of these patients have localized or very slightly locally advanced disease. It's very high-risk prostate cancer. These patients still, despite that, want to undergo prostatectomy. So it's a specific population of patients, and they're candidates for radical prostatectomy with that pelvic lymph node dissection. This patient population in the trial underwent a perioperative hormonal therapy approach with apalutamide and ADT, and then underwent their radical prostatectomy, and then had apalutamide and ADT on the back end, 6 months on either side of the radical prostatectomy, or they received 6 months of ADT, radical prostatectomy, and 6 months of ADT on the back end. And the study is fully enrolled, and we will see at some point, hopefully in the near future, whether this perioperative intensified hormonal treatment actually improves outcomes for patients. We'll also have the data from the radical prostatectomies to be able to understand correlatives based on that intensified strategy, so we understand what happens when we use these medications prior to surgical treatment. The primary endpoint here is pathologic complete response rate, so looking at that prostatectomy specimen, as well as metastasis-free survival. There is also the phase 3 Atlas trial, which is looking at apalutamide and ADT in high risk and locally advanced prostate cancer. These patients, as you could see here, are getting apalutamide, ADT, and radiation therapy. So patients with high risk disease are coming in and being randomized to receive apalutamide and a GnRH agonist as neoadjuvant and then concurrent with the radiation, all the way up to that full duration of treatment of ADT and apalutamide versus just the placebo and bicalutamide with a GnRH agonist. And so here we'll see a primary endpoint of metastasis-free survival, and we'll understand whether patients need that or can benefit from that intensified hormonal treatment in the high-risk setting. DASL-HiCaP is also in this space. It's a little more complicated, including patients with very high-risk localized prostate cancer who are going to be treated with definitive radiation, or if they have PSA persistence or rise after radical prostatectomy and are getting post-prostatectomy radiation. These patients are getting enrolled and are getting randomized to ADT and darolutamide for 96 weeks, or placebo here for this placebo and ADT, I believe, for 96 weeks. The primary endpoint here is metastasis-free survival. This study is also enrolled and as a radiation trial, so all these patients are getting radiation. So we will see where this goes, and hopefully we'll find a benefit for people as well. So moving on from all of those studies that are piquing our interest to a study that has reported out, the phase 3 Embark trial is a trial that has affected the treatment landscape and is one that I think we're all quite familiar with. But just to review, this included a patient population with high risk, non-metastatic, castration-sensitive prostate cancer or biochemical recurrence. And it was high risk because these patients had a PSA doubling time of less than or equal to 9 months. They had CTs and bone scans that were negative for radiographic evidence of disease, and they had testosterones that were over 150, so in a normal or normal-ish range for most of our clinical settings. Patients were enrolled and they were randomized to receive enzalutamide and leuprolide, or enzalutamide as a single agent, and they were followed for a metastasis-free survival primary endpoint. They had multiple secondary endpoints, including overall survival, time to other neoplastic therapy, safety, patient-reported outcomes, and others. And importantly, at week 37, if they had a PSA that was at the less than or equal to a 0.2 level, they could actually have a period of treatment holiday within this study, which I think is important because in biochemical recurrence, we often have used an intermittent androgen deprivation therapy strategy. So really interesting 3-arm trial that met its primary endpoint. So here we can see this is the MFS, metastasis-free survival curve, for patients who were receiving leuprolide and enzalutamide versus leuprolide alone. And what we can see here is a hazard ratio favoring the leuprolide and enzalutamide combination at 0.42. So a really beautiful reduction in the risk of developing metastatic disease or death with a p-value that's highly statistically significant. Also importantly, a key secondary endpoint of interim OS is on the right here with a hazard ratio of 0.59 and that p-value of 0.142 that continues to mature. So this is the combination arm. And here we can see the enzalutamide combination with the key secondary endpoint of PSA progression, favoring the enzalutamide ADT combination versus leuprolide alone. Hazard ratio here, 0.07. So, and as you can see, these curves actually quite maximally separate. This is highly statistically significant. Here we can see that enzalutamide monotherapy also improved metastasis-free survival when compared to leuprolide alone. Hazard ratio here, 0.63, also highly statistically significant. And so this has led to, in November 2023, an FDA approval for patients with high-risk biochemical recurrent prostate cancer to be treated with enzalutamide with or without leuprolide or an ADT backbone. So you can use enzalutamide monotherapy, you can use that combination as well. And you can see here the secondary endpoint of interim OS continues to mature. I think importantly, we of course have to review the safety data, which is going to be different depending in the arm or on the arm that was used for treatment. With enzalutamide combination, leuprolide, and enzalutamide monotherapy all having what we would consider a relatively tolerable safety profile with no new safety signals from our experience with these agents previously. What's not highlighted here is that there are some differences in those specific adverse events, with gynecomastia, breast tenderness being more common on enzalutamide alone versus the arm where we might have the leuprolide as well. So those are some differences. But importantly, we also had some information about that treatment suspension and treatment holiday. We can see here that in this study, and to remind everyone, as I just said, if those patients got to week 37 and the PSA was less than 0.2, they could have a treatment holiday. That was possible in about 86% of those patients who were on enzalutamide monotherapy versus leuprolide. It was about 67% of patients. So more patients who were in an enzalutamide-containing arm were able to take that holiday or that suspension. And so this is an opportunity, I think, for patients to take a break if that is something that's within their treatment preferences. So just to think about some other studies, this is the ARISTEP study, which is a patient population that has high-risk biochemical recurrence. And in this trial, that high-risk biochemical recurrence is defined with a PSA doubling time of less than 12 months. All of the patients in this study have to have PSMA PET positive disease, and they are randomized to treatment with ADT and darolutamide or ADT and placebo, with plans to potentially use SBRT to all PSMA PET identified visualizable disease. And they're followed for a metastasis-free survival endpoint by PSMA PET. So a little bit of a different endpoint than we've seen previously with MFS in other studies defined by conventional imaging. That is a secondary endpoint, and you can see others listed there as well. And just in terms of an ASCO GU 2025 update, the Aramon study, which is a study actually that Dr. Smith participated in, was also reported. Dr. Smith, do you want to share any insights? All right, I will keep talking. So a really interesting study that was looking at darolutamide as a single agent here. And this is really just some of their primary endpoint information. I think more data is to come. But in the primary endpoint, we can see that darolutamide monotherapy increased baseline testosterone levels in this patient population as we would expect. So if you're not giving this with a GnRH agonist, you'll have an antagonist activity that's unopposed. And so it increases your testosterone level. They found that this was to a lesser degree than reported with some other AR pathway inhibitors, but it was there. And they had actually, I think, really nice PSA responses, deep PSA responses at week 12. This study continues on in follow-up. So more to come from the Aramon study. And this was a poster, so please enjoy checking it out on the virtual meeting over time. So I have just talked for a long time, both of you, and it's time for us to have a panel discussion to kind of think through some of this information. I'd love to hear what your thoughts are. This is a high-risk setting. The data from Embark, of course, has changed practice, is newly available. What are your thoughts? Do you use these agents in the real world? Do you have a preference for using something like enzalutamide alone or in combination? Matthew, why don't you start us off?
Yeah, absolutely. So at a high level, I'd say that and some of this will come when I talk about MHSPC, although I won't make this specific point then. There's really kind of a convergence of treatment when we think about this, right? So a number of things are happening in routine clinical practice. We're doing a lot of PSMA PET CT, so there's fewer and fewer patients with biochemical only recurrence because we identify their local or distant disease when their PSA is rising. An increasing number of patients with high risk or very high risk disease are reclassified as low volume de novo metastatic disease. And so there's a lot of that going on. But at the same time, there's therapeutic advances that lead to similar treatments, even when we're reclassifying patients from high risk localized disease to low volume metastatic. And by that, I mean, there's increasing evidence for intensification of systemic treatment for clinically localized disease. There remains a role for obviously definitive local treatment, typically with radiation in that setting. But in patients with low volume de novo metastatic disease, what do? We do the same thing. We intensify their systemic treatment and often treat the primary. So I think it's something really to keep track of. And in a lot of ways, it's like, I think we're just become more precise in the way we treat our patients. It's not like the old days of a decade or more ago where it was this very dichotomous management. You went from high risk to metastatic, your treatment changed completely.
Yeah. That is an interesting comment. I mean, it's often the same treatment, and it's an interesting conversation with patients that, well, whether it's this, whether it's that, we're kind of going to do a very similar approach. Sandy, we have a question that's come in here about the Embark population, so high-risk BCR. To Matthew's point, we're using PSMA PETs often in that setting. What do you do if a patient meets criteria for Embark, but then has a PSMA PET scan that is positive? How do you think through the management of that patient?
Yeah, I think we've seen patients who have had, so the Embark was with conventional scans, and I think the group at UCLA actually used the exact Embark population and looked at the PSA doubling time and looked at the data with PSMA scans. And not surprising, they did find that more than half of the patients ended up having metastatic disease. So I think Embark in some ways is for patients with low volume metastatic disease. And I think the message is the same, right? We have ADT intensification that improves outcomes. But I think the unique thing about Embark is it gives us an opportunity to treat patients with monotherapy. One of the messages that I see that's come along is that, are we over-treating a lot of patients, right? So there is some interest in sort of individualizing treatments and thinking about patient-specific interests. Most patients want a treatment that doesn't lower testosterone. So I think the unique feature about Embark is this monotherapy enzalutamide arm that does allow you to stop therapy once PSA becomes undetectable. But I wanted to make a point about some of your presentation that you did, that in general, I don't know, 10 years ago, I think medical oncologists were really not that engaged in patients with localized disease. Now it seems like all the referrals we get, anytime somebody gets radiation, the question is, what's the ADT that needs to happen? What's the duration? Should it be intensified? But it's really interesting that we now have some surgical trials as well, that I think the message really here is that this has become a multidisciplinary approach, and we are working with our urologists and radiation oncologists with really the message about what's the best therapy and for a given patient. And I think there are a lot of more questions than answers that we have now.
That is definitely true, which keeps it exciting, right? But it does make it interesting in clinic. I am going to ask just one more question or two, but this one is just very pointed. Matthew, if you have an EMBARK patient who has PET positive oligometastatic disease, say 2 to 3 spots, it sounds like Sandy, she's going to go for the systemic treatment, maybe monotherapy, maybe combination. Are you, Matthew, going to also add in SBRT?
We are. I mean, I think the challenge in oligometastatic disease is how you define it, right? And so it can be defined anatomically. That's pretty simple and straightforward. But there are other considerations that I think about, like, tempo of disease. It's very different if you have, 2 bone metastases, 7 years out from your prostatectomy versus 7 weeks out from your prostatectomy for Gleason 10 disease. So you really think about those things. But one of the appeals, I think, about radiating a limited number of sites of metastatic disease is it makes it easier to recommend a treatment break. So there, I think if I can radiate all of the known sites of disease, I'm more enthusiastic about providing a treatment holiday for the patient.
Great, thank you. That makes sense. And Sandy, you mentioned kind of the benefit of having that enzalutamide alone arm. How do you talk to patients about using enzalutamide versus enzalutamide with like a GnRH analog backbone? How do you make that choice?
I think many of these decisions come from the patient itself. This is a patient who's telling you, do I have to go on ADT again? The side effects from that testosterone lowering therapy was just so harsh on me. Is there an alternate, right? So that's the decision that's driving this choice of your therapy. I do think, to your point that you said about the side effects are a little bit different. The gynecomastia is something that is real, especially when you do this monotherapy. So I think counseling patients about that. We used to do breast radiation in the past. I think that's becoming another issue as to if you choose this therapy, should you be talking to your radiation oncologist about breast radiation? People talk about tamoxifen. There are other drugs that you can give. But once they develop gynecomastia, it's almost irreversible. So you should think about this before you make the decision to do that monotherapy.
Great. Well, thank you both for that. And we will now move on to navigating therapeutic choices in metastatic hormone-sensitive disease with Professor Smith.
Good evening. So it's really nice to present this topic. And it's really important to remember that patients with metastatic prostate cancer have a relatively poor prognosis. Second point to make here is that said, there's considerable heterogeneity of outcomes in this disease. And prognosis is very different according to volume and manner of presentation. And the case is made here from this study where there are markedly different overall survival outcomes for patients based on their manner of presentation, de novo versus recurrent, and extent of metastatic disease here simply dichotomously described as low volume versus high volume. But if you look at, de novo high volume patients in this study had a median overall survival of only about 3.6 years. Patients with synchronous low volume disease survived on average more than twice as long as that. And that's really something to think about when we make decisions about appropriate management. Despite consistent level 1 evidence for improved overall survival by treatment intensification, though, adoption of treatment intensification in the U.S. has been poor. Many patients still receive androgen deprivation therapy as monotherapy or as combination with the first generation anti-androgen. For most patients, that's an unsupportable treatment plan. And there's been a lot of attempts to understand that. There does appear to be some discordance between major academic medical centers and large hospitals versus community settings. There may be a variety of factors that drive those differences, including, candidly, differences in the patient population, case mix, access to these drugs, both economically and otherwise, comfort with AE management, and I suppose to some extent, limited familiarity with the data, but given the large number of trials, like the latter, hopefully is no longer the case. And part of the goal of these kind of educational programs is to eliminate that barrier to care. So here's some of the data that make this point. This looks over a 3-year span, like after we had clear evidence for treatment intensification with both docetaxel and ARPIs. And as you can see up on the top there, ADT monotherapy was among the most commonly prescribed treatment for patients as initial therapy for metastatic prostate cancer. So really underutilization of evidence-based care. I think there was a question on Alicia's slide is like what to do in a busy clinical practice. We're all busy, right? Change the narrative. Like I no longer think about it like the way we thought about it after docetaxel was approved is I'm starting ADT and then I'm going to make this secondary decision about docetaxel. The default should now be ADT plus an ARPI, and who am I not going to do that in? And I make that decision when I meet the patient. There's no need. Patients aren't interested in history. They're interested in recommendations, right? You don't need to explain to a patient that we used to give ADT alone, now we give 2 drugs. You just say, we now give 2 drugs. It's just that simple. And it actually makes it a lot easier for patients to accept that recommendation. And I've adopted prescribing the drugs on the day I meet patients, particularly those with de novo metastatic disease. The data is really candidly overwhelming, supporting treatment intensification in MHSPC. These are the studies summarized, looking primarily at systemic treatment, but like you have 3 trials that showed an improvement in overall survival with the addition of docetaxel. Subsequent trials looked at the addition of ARPIs to ADT, consistent, similar large treatment effects on overall survival. And then a couple of newer studies have looked at so-called triplet therapy. They were designed at a time when docetaxel had been shown to improve survival and ARPIs were being evaluated, hence the triplet therapy in that order. The study on the top, Stampede RMH, also looked at the role of treating the primary tumor, and at least in patients in the low volume subgroup, a pre-specified subgroup in that study showed an overall survival benefit, which, as you might have heard from the podium yesterday, really, or a question that came up yesterday in the oral abstract session, was of a magnitude that's really similar to what we do with systemic therapy. So an important consideration for well-selected patients. So here's some of the early evidence. This is charted in Stampede, showing an improvement in overall survival in patients receiving intensification with docetaxel added to ADT. The benefits in these studies in both subgroup analysis of the individual trials and additional follow-up meta-analyses pretty clearly made the case the benefits are primarily restricted to patients who have poor prognosis disease, however defined, primarily de novo, high volume disease. And I don't know that that's been sort of biologically explained, although there are different molecular markers in patients with poor prognosis disease and those with like recurrent low volume disease. I think part of it is really an opportunity issue. Patients with very poor prognosis disease often will progress quite quickly, and in some cases, like fairly explosively, and they may miss the window of treatment because this idea that I can just intensify later may not work out because patients progress and may no longer be candidates for at least docetaxel in this setting. The evidence from ARPIs, I'd say, is even more compelling, with consistent large impact on overall survival. Titan with apalutamide, Arches with enzalutamide, and Latitude, the first ARPI study with abiraterone, showing these large treatment effects. It's really stunning that the hazard ratios for overall survival are nearly identical across these trials that span the globe of different drugs, slightly different patient populations. Really quite extraordinary. Now, what we learned from the doublet trials really is the addition of either docetaxel or an ARPI improved PFS and OS. In addition to efficacy, QOL was maintained or improved in patients who received doublet therapy with the ARPIs. And while not done exactly in this sequence, this led to the question of whether there's a role for triplet therapy. And a couple of trials have addressed that question. Piece 1 was a complicated trial for the 4-arm trial that considered the question of triplet therapy in a subgroup of patients who received docetaxel as part of and ADT as part of best standard of care. In that subgroup, there was a significant improvement with the addition of ABI to ADT and docetaxel with a hazard ratio of about 0.8. And then ARASENS was sort of a standalone, really designed to address the triplet therapy question. So ADT, docetaxel plus or minus darolutamide, showing a large improvement in overall survival. Curves separate early and remain separated. And you'll note that the hazard ratio is very comparable to the earlier hazard ratios I showed you for doublet therapy. So even in the face of a more active control, let's say, you see this meaningful impact on overall survival. The planned pre-specified subgroup analyses all showed a consistent benefit in favor of triplet therapy. Should come as no surprise, really, because when you see a big treatment effect, usually it carries through in the forest plots. I was actually surprised when we published the data. There was tremendous interest, tremendous questions that said, what about high volume versus low volume, and synchronous versus metachronous, and high risk and low risk. Those are really, in my view, mostly docetaxel questions, which we can't answer in ARASENS because everyone received docetaxel. But nonetheless, we tried to satisfy the community and did those analyses. And you can see there's a fairly consistent benefit in favor of triplet therapy compared to ADT and docetaxel, regardless of the risk group evaluated. Now, there's some updates at ASCO GU that are sort of relevant to the triplet therapy with ADT and darolutamide. This is one of those showing that that the benefits were similar between younger and older patients. Again, not a docetaxel question because all the patients received docetaxel, but consistent with other ARPI analyses, the benefits are similar for younger and older patients. There were some other questions that were addressed at this meeting, including the role of G-CSF, which in Europe is commonly done prophylactically, at least I understand from my colleagues in Europe. In the US, we tend to do it more reflexively in patients who develop neutropenia with the first cycle. But the rates of requiring G-CSF were similar with or without darolutamide, not a particular surprise, and reassuring that didn't really have an impact on the study outcomes. Now, one of the holes in the data, at least from the darolutamide story, was, well, do you really need the docetaxel? And it wasn't the question we expected when we designed ARASENS, but the field kind of moved on, and I think compelled by the remarkable benefits of oral, well-tolerated ARPIs, the question became do we really need to give docetaxel? And this was the purpose of ARANOTE, to really just provide the data about doublet therapy with darolutamide. This was, of course, done subsequent to ARASENS, or reported subsequent to ARASENS, so done mostly, almost entirely ex-US, I believe, and looked at ADT with plus placebo versus ADT plus darolutamide, no docetaxel in either group, with the primary endpoint of rPFS, and to no one's surprise, it's quite effective, shows a marked improvement in rPFS with very good safety data, very consistent with the previous randomized phase 3 studies of darolutamide. So this is now under review for potential label expansion. I think most of us in clinical practice use darolutamide near label without docetaxel and MHSPC. It provided this is approved, I think that'll just make that easier with payers to get that pre-authorized. Number of updates at ASCO GU as it relates to this study. Fred Sod reported that the outcomes by risk groups, again, very similar to the other studies of ARPI doublet, showing benefit in both high volume and low volume disease. In fact, low volume benefit was quite remarkable there with a hazard ratio, I think, of 0.3 for rPFS. The study was not designed to evaluate overall survival, but there was sort of consistent benefit across secondary endpoints, as you can see summarized there. This is an ASCO GU update on apalutamide. This we heard from the podium yesterday some really interesting data that the lutamides basically fare better in older populations, presumably because of their comorbidities, relative to abiraterone. So consistent with that high-level observation yesterday, this abstract looked at the safety of apalutamide in older patients and those with the usual comorbidities, including cardiovascular disease, and very comfortingly found that the drug was safe, well-tolerated, and had similar efficacy in populations with those who are older age and had those comorbidities. Here's another slide showing some update. 70% of patients had rapid PSA declines at 6 months with APA and ADT, consistent with the results of the phase 3 Titan study. And it does raise interesting questions about treatment discontinuation and de-intensification, and maybe those questions will come up in the panel discussions. So I think there's a lot of things to consider in making individual patient decisions. There are differences between the agents. There's different safety profiles for abiraterone plus prednisone versus the lutamides. That is important for patient selection. I'd say the typical patient could probably tolerate any of these 4 approved ARPIs, but there's going to be individual patient selection based on important comorbidities, foremost among them congestive heart failure, difficult to control diabetes. Either of those conditions are, I'd say, poor fit for abiraterone and prednisone. History of seizure disorder, pretty rare, but would be a poor fit for patients with either apalutamide or enzalutamide. But those are things to consider. I think it remains an open question as to the optimal selection of patients for triplet therapy, in this case meaning adding docetaxel to ADT and an ARPI. Current NCCN guideline pretty much is based on the subgroup analyses and meta-analyses of the docetaxel doublet trials, where you see most of the benefit in patients with poor prognosis disease. I think most of us have landed on kind of an appropriate set of disease characteristics includes de novo high volume disease, but that's a fairly crude way of estimating prognosis. I mean, as a group, they do poorly, but there's certainly, you'd be missing some patients with very poor prognosis disease. I'll be interested to know what my co-panelists think about that, but we certainly consider other things, very young, healthy patients with low volume disease, however defined, we would consider for triplet therapy, particularly if they had other markers of poor prognosis, primary pattern 5, Gleason grade, tumor genetic testing that shows 1 or more loss, pathogenic mutations in tumor suppressor genes, other adverse prognostic factors are certainly, I think, considerations that yet haven't made their way into formal guidelines. So I have a case to present, which is really intended kind of to be a contemporary case that brings out a number of relevant issues, both as the way we identify the disease and how we make these sometimes challenging decisions about optimal management of patients with presenting with metastatic disease. So this is a particularly young guy, 56-year-old man who had his first screening PSA at 30. He was asymptomatic. Prostate biopsy showed extensive Gleason 5+4, 4+5, and 4+4 disease. Prostate MRI showed a confluent PIRADS 5 lesion throughout the left peripheral zone, extending from the apex to the base, and a probable metastasis in the right iliac bone. This was a few years ago, and so he initially had a bone scan, that showed a metastasis in the right iliac bone, consistent with the MRI finding. And then this was early days of PSMA PET CT, so we then got a PSMA PET CT. We would have just skipped the bone scan now. But you can see the metastasis in his right iliac bone, but he had other sites of metastatic disease that were not detected on the bone scan, including that cervical spine metastasis shown on the right, and a few other bone metastases. So I think all in maybe 5 or 6 bone metastases throughout his skeleton by PSMA PET CT. So the question becomes, what is his optimal management? Do you want to take a shot at that? Alicia,
Sure.
How would you manage such a patient in your practice?
Sure. So, this patient, by traditional definitions, has low volume disease. It sounds like he had a bone scan with that one area, and then has sort of a shift in his stage or in his volume risk, I guess, volume status, by the PET scan. So technically low volume disease, de novo metastatic. So I think this is the perfect opportunity to have a conversation. And actually one of our attendees asked a question about, do you ever kind of take a patient and offer a kitchen sink approach that might include a triplet as well as radiation to the prostate? And I think this is that kind of patient, presuming that this 56-year-old is otherwise, healthy and actually wants to be aggressive in his management, as many 56-year-olds would want to be. So I think de novo status, absolutely an opportunity to consider ADT docetaxel and darolutamide or abiraterone. In fact, you can do that in ARASENS at least. There were no restrictions. You could put any patient who was chemo fit into this trial. So this is a good opportunity. And then I think because this is truly low volume disease on conventional imaging, I would also offer this individual consideration, at least, of radiation of the prostate. And I would say you can offer that in high volume disease as well. It's just that your goal may be for different benefits. In that case, maybe to reduce urinary complications or GU complications, not necessarily to improve survival as we saw in the STAMPEDE study. But what do you think, Sandy?
I mean, I agree with everything that you said. These patients who come into our clinic, it just takes so much time. I mean, this guy at 56, coming and seeing us is probably devastated with this diagnosis. So to tell him that he's now got metastatic disease, we talk about the systemic therapy, the side effects of systemic therapy. Now we have to talk about radiation to the prostate, maybe even metastatic directed therapy. And then there is an issue of how do you counsel them for bone health? How do you counsel them for all of the adverse events that they're going to have from androgen deprivation therapy? Here is a young guy. Should we be talking about genomics for him? So I think it's really a detailed discussion, but I think patients deserve that. They want to know about all of this. So I think I would agree. I definitely would bring up the conversation of chemotherapy. And I think triplet seems very reasonable for this patient, and then include some of the other things.
Yeah, I think it's, we generally think about like triplet therapy as sort of one end of the spectrum, high volume de novo metastatic disease, and then low volume metastatic de novo, like the patients we'd offered doublet and prostate radiation. There is some overlap, and this is the occasional patient that I think meets that kind of criteria. I think for the busy clinicians in the audience, though, what are the key things we need to get across to this patient? I'll say it again. He doesn't care about history. Like, he doesn't want to know the history of prostate cancer development and tell him we used to do this and then we did this. And like, there's an occasional patient that may be interested, but for the most part, they want to know what you recommend. So when I met this patient and similar patients, I tell them, here's the deal. You need systemic therapy. We're going to start with 2 drugs. When you're back monthly for the next few months, we're going to discuss whether there's also a role for chemotherapy. And I'll start their ADT on that visit, prescribe their ARPI, and I'll also typically get, we mostly use blood-based tumor genetic testing. I do that on the day I meet them. Why is that? Because I want the results when they come back for their next injection, the next, GnRH antagonist injection, typically a month later, or whatever you're giving them for ADT. I'm going to see them back soon anyways to assess the safety of the ARPI and make these secondary decisions about chemotherapy. But you want that information at the next visit, so you can do all that. So you can really you can kind of hit a number of really high-level evidence-based decisions straight away. You don't have to belabor the point about whether or not you're going to add an ARPI. This patient needs an ARPI. You can debate whether chemotherapy is necessary or appropriate. We chose to do that in him. I think he can make a good case to radiate his prostate, and I chose a patient here who had, a particularly large primary tumor as well, and not much in the way of metastatic disease. But hopefully those are helpful sort of comments as you think about similar patients in your own practice. And I think now we move on.
I just have a quick question for Sandy. Matthew mentioned genomics, and he probably means potentially multiple types of genomics. What kind of genomics do you normally get in a hormone-sensitive patient?
So we send them to the genetics counselor. We don't do it, unlike you, in our clinic. So I do make a referral for germline testing. I think somatic testing is helpful at this time. Maybe it won't change what we do, but I think in thinking about clinical trial enrollment, it's nice. And it's good to have a workflow so that you do it and it's taken care of and you don't forget about it. One thing that I wanted to bring up is, Decipher testing, right? It's available to us. And for these patients with low volume disease, I think the Stampede group showed some interesting data where they looked at Decipher high. And even for patients with low volume disease, if you were to have a high Decipher, they seem to benefit for chemotherapy. So in these cases where you have some uncertainty, I think additional genomic testing may be helpful. So I don't do it routinely, but I think if I want questions about what's the duration of hormonal therapy, should we add chemotherapy, more information is helpful.
Great. Well, thank you. Thank you for that. And now we are on to Professor Srinivas, who is going to tell us about integrating modern therapies into mCRPC treatment plans. Take it away, Sandy.
Thank you. So when we think about CRPC, I just wanted to start off with what are our available classes of drugs that we have. So we have the traditional hormonal drugs. These were the first drugs that were approved in CRPC now more than 2 decades ago with enzalutamide and abiraterone in the post-docetaxel, and then they moved to the pre-docetaxel space. And then enzalutamide, apalutamide, and darolutamide were also approved in the non-metastatic CRPC. Then we have immunotherapeutic drugs. I mean, Sipuleucel T, again, it's been about 20, 25 years, I think now. And the first therapeutic immunotherapy for any disease. And then pembrolizumab for that small group who are MSI high. Again, it's not prostate cancer specific, but now you have some small trials showing that patients who do have it have a prolonged and durable response to pembrolizumab. So again, yet another reason why we should be doing genomic testing. And then cytotoxics with docetaxel and cabazitaxel. And finally, a DNA damage class of drugs, which include radium-223, our monotherapy PARP inhibitors with olaparib and rucaparib, lutetium-177. And then we now have this whole class of PARP inhibitor combinations. So we have 3 of those that are approved. So despite this list being really long, when it really comes to the patient in front of you, I think there are a lot of unmet needs. We really don't have like level 1 evidence. What's the best sequencing and how do we use these drugs? We find that there's a lot of cross-resistance between drugs, especially the ARPIs. So if somebody has had a prior abiraterone or enzalutamide, the likelihood of having another response is low and the duration of response is very limited. And then despite that big list that I showed you, the field has sort of moved. We are using many of these drugs now in the front line. So all of the hormonal drugs, the chemotherapy drugs. So when they really come to CRPC, our options are somewhat limited. And I think selection is based on many factors, right? What's the time since they had the last drug? If somebody's had if they had a ARPI in the localized disease, you do it for a finite duration. So you think about that when they have CRPC. Are they symptomatic or is it just an asymptomatic rise in PSA? Do they have bone disease alone or is it a patient with lymph nodes and visceral disease? Do they have any genomic aberrations? Now that we have PARP inhibitors, I think integrating that into our treatment decision becomes important. Is it an oral drug versus IV? We have some choices in terms of patient preference and what they want. And as oncologists, we have always done this looking at performance status and frailty of a patient. So I think many of these are what we do on an everyday basis when we think about that patient in front of us. So in my talk, I'm just going to talk about what new data do we have about the existing drugs that might help us. So the first drug that I'm going to cover is radium-223. So this is a drug, again, that we have had now for a decade. It was approved in 2013 based on the ALPSICA trial, which gave an infusion of radium for 6 doses, each a month apart, versus placebo, and showed an improvement in overall survival. And that survival was seen irrespective of whether patients had docetaxel exposure or not. So we do use radium in the clinic for people pre or post docetaxel, and you can see that the hazard ratios are somewhat similar for the two groups, with an improvement in overall survival of around 4 months compared to placebo. So what we do as medical oncologists when we have a drug, we try to combine them to see if we can get some additive effect. So the first trial that was done was combining radium with abiraterone in the ERA-223 trial. Surprisingly, this trial was stopped early because they found that patients who got the combination had a much higher number of fractures. So this is definitely a combination that's not used, but there were lessons learned from this trial. So in parallel to this trial, there was a trial that combined radium with enzalutamide in the PEACE-3 study. So the investigators looked closely at these patients and found that those who were getting the combination with enzalutamide and radium did have a higher number of fractures, especially if those patients were not getting a bone protective agent. So they were really smart and mandated the use of bone-modifying drugs in all of the patients going forward. And you can see once that was instituted, the risk of fractures really came down. And early this year, we saw the results of the PEACE-3. So what's the PEACE-3 trial? Again, it's combining radium with enzalutamide. These are for patients who have first-line CRPC. They have had no prior therapy with enzalutamide or radium, and no prior concomitant therapy with CYP17. So this is really an ARPI naive patient population. They were randomized to either enzalutamide plus radium, again given at the FDA-approved schedule, or enzalutamide alone. The primary endpoint was rPFS, and I was surprised, but there was an improvement in both rPFS and also overall survival, combining radium with enzalutamide. And it's a pretty difference. You can see a hazard ratio for rPFS at 0.69 and a nice separation of the curves favoring the combination, and also an improvement in overall survival with a hazard ratio of 0.69. Okay, so that's radium. So the next drug that I wanted to cover was lutetium-177. So this is now an FDA-approved drug based on the VISION-3 trial. But what's interesting is that, again, this drug is now moving into earlier and earlier lines of therapy. So lutetium-177, as approved by the VISION study, is really for patients with CRPC who have had ARPIs, who have had taxanes. But we are now looking at use of this drug in the pre-taxane space. So we have the PSMA-4, we have the SPLASH study, but there's also trials looking at lutetium in much earlier lines. So PSMA addition is a trial exploring lutetium in the hormone-sensitive space. So this is ADT intensification with or without lutetium. And there's also PSMA-DC, which is delaying castrate resistance. And this is a trial looking at lutetium plus SBRT for those patients who may have oligometastatic disease. So a lot of trials in progress looking at lutetium. So let's talk a little bit about the VISION study. So you're familiar with this trial, really looked at patients who had a positive PSMA scan, who were then randomized in a 2-to-1 fashion to either best supportive care plus lutetium, which was given IV for 6 cycles, and versus best supportive care. The primary endpoint was a co-primary rPFS and OS. And here are the results. The trial did demonstrate an improvement in overall survival, hazard ratio of 0.62 for OS, a nice separation of curves with a median OS of 15 months versus 11. You can see that the rPFS was also pretty significant with a hazard ratio of 0.4, with a median rPFS of 8.7 versus 3.4 for the best supportive care. So this led to the FDA approval now more than 2 years that we have the use of lutetium 177. So what data do we have? Moving it earlier in the pre-chemotherapy space, I think many of our patients are elderly, may not really be chemo fit. For those frail patients, this is certainly a great option to have. So this is the PSMA-4 trial, which took patients with metastatic CRPC and randomizes them to either lutetium or the alternate ARPI. So this is the switch. And the interesting thing about this trial was that they did allow for crossover, and many patients took advantage of this crossover. So the crossover was pretty significant in this, that really confounded the results of overall survival. The trial's primary endpoint was rPFS, and you can see that the trial was positive. We had a hazard ratio of 0.41 with a median of 12 for the rPFS versus 5.5 months for the ARPI switch. So I think this is sort of awaiting a regulatory approval for the pre-docetaxel space. At this year's ASCO, Dr. DeBono spoke about some ctDNA as well as PSA results, sort of correlating, what can we learn from these patients at baseline and looking at these patients at cycle 2. And his message was that cycle 2 informed us a lot about both prognosis as well as response to therapy. You can see that those patients who had a decrease in their ctDNA and a drop in PSA at cycle 2 had a better outcome both in terms of rPFS as well as OS. So what are the side effects? What do we tell our patients as we counsel them about lutetium 177? They certainly have some GI side effects, so some nausea and diarrhea. There is some suppression on the bone marrow, so having CBCs prior to their start of treatment is standard. You can expect some fatigue. I think pain flare is an important thing to just tell patients so that they are aware of it and they're not caught by surprise. And then some uptake in your salivary glands. So definitely a dry mouth is something that we should be telling them. There is some uptake in the kidney. So there is renal dysfunction and some worsening of a creatinine. So your standard lab tests that you need to do prior to start would be a CBC and a metabolic panel. So the good news is that there's more in this RLT space. So lutetium is a beta emitter, but there are a lot of other drugs looking at alpha emitters such as actinium, and I think there are different sources of isotope emitting besides just lutetium. There are different targets, not just PSMA. So I think the whole RLT field is just exploding, and I think we will have more therapeutic options that will be available for our patients. So I'm going to shift gears a little bit and talk about the PARP. I know many of you in the group voiced that was a difficult decision about what we do with PARP combinations. So this was an important one that, despite having PARP inhibitors available, despite knowing that maybe 1 in 4 of our patients harbor a germline mutation, in the real world, with looking at more than 1,000 patients, that many of them don't get testing. So only 60% of patients received HRR testing. And of those patients, just a third of them received a PARP inhibitors. So I think testing, if we don't test, we wouldn't know. So just having these drugs available, I think the message really here is that we should be doing testing for our patients. So we have 3 combinations. We have Propel that looked at olaparib plus abiraterone, which is now FDA approved, but just for the BRCA mutated patients. Similarly, an alternate PARP with niraparib and abiraterone based on the Magnitude trial, also approved just for the BRCA mutated patients. And then a third PARP with an alternate ARPI, so talazoparib and enzalutamide, based on the TALAPRO-2 trial, approved for a broader indication for all HRR mutated patients. So I'm just going to go over the details of this in the next few slides. But really, there's been a lot of interest in combining an ARPI with PARP inhibitors. That the notion is that AR inhibition upregulates PARP repair pathways, and that results in synthetic lethality really with the ADT and PARP inhibition. So this concept really led to these 3 combination trials. So the first one was Magnitude, which looked at niraparib plus abiraterone, and you can see in the BRCA group. So this trial really enriched for patients who had the BRCA mutation, and you can see that the RPFS really is significant with a hazard ratio of 0.55, with an almost doubling of RPFS for the group that harbored the BRCA mutation. So this led to the FDA approval in 2022, but again, it's just limited for the BRCA population. The second trial is the Propel against Abi with olaparib. You can see, again, very similar to in fact, even a higher magnitude of benefit compared to the Magnitude study. You can see, I think the hazard ratio here was 0.23, really an impressive separation of curves. And you can see the overall survival also having a hazard ratio of 0.29. So for that BRCA mutated patient, the combination has really been very impactful. And this led to the FDA approval in 2023 for this combination. Then came TALAPRO-2, looking at talazoparib plus enzalutamide. This was approved, again, as I said, for a broader HRR group, which includes not just BRCA, but includes all of the other HRR mutations. So this combination for the HRR population resulted in an improvement in PFS. The hazard ratio here again is 0.45, and this was presented a year ago now. At this meeting, we saw the update for the all-comer population. So TALAPRO-2 included patients who had HRR mutations, but also had an unselected patient population. So the curve to the top was presented by Dr. Agarwal, looking at the unselected patient population, where there was an improvement for overall survival. So these are patients who really didn't have an HRR, who had the combination of talazoparib plus enzalutamide, had an improved overall survival compared to enzalutamide alone. The hazard ratio here, I think it's like closer to 0.8. And you can see that there was also an update of overall survival in the poster session. And the bottom one is looking at the HRR deficient patients. So to me, I can see a difference that the benefit appears to be certainly higher in the patients who have the HRR mutation compared to the all-comers. And I think this hazard ratio was like 0.6 for those who had an HRR deficiency. So what are the side effects that we can expect with the combination? I think in general, PARP inhibitors as a class effect, they have really the two hematologic side effects and GI side effects are what we are counseling our patients. So anemia, thrombocytopenia, and nausea and GI side effects. Very few cases of MDS and AML have been reported with, I think, all of these combinations. So here are the side effects from all three of the trials. I think they all have similar class effects that really just paying attention to the anemia and the GI side effects, maybe differing in grades based on the trial and the combination that you see. I just wanted to bring this up because I think, that all three trials that I presented were all in patients who were ARPI naive, right? I think that's really an important one to bring up. So I just put out for you in this that in PROPEL, Magnitude, and TALAPRO-2, if you look at the prior ARPI, it's in PROPEL, it was less than 1%. In Magnitude 3 and in the TALAPRO-2, 8%. So I think it's great that these trials were positive, but do we have the patient population today who are ARPI naives? And that's an important consideration. There were, I think, about 25% in all of these three trials that did have prior docetaxel. So I think this becomes important as we think about how to integrate these new data that have come with our patients today. And since we are using many of these drugs in earlier lines, do we have the patients today for this group of patients? And the good news, again, is I just wanted to end up with this slide that we have a lot more trials and lot more classes of drugs that are in clinical development. I think we saw the drug that targets P10 and through AKT inhibition, so the Capitello 280 trial looking at this inhibitor in combination with docetaxel. There was a press release that it was a positive trial. There are many other trials looking at AR degraders. We have CYP11 inhibitors. Let's see, I'm also excited about some of the PSMA-based ADCs, PSMA-based BiTE therapies. So I think some of the options maybe in the next 3 to 5 years for our patients with CRPC are going to be a lot more than what we have today. I think that's my last slide.
That's wonderful. Thank you so much, Sandy. And actually, it was almost as if this was planted, and it was not. But Sandy, we are about to launch a study called the TALENT trial, which is a study of patients who had progression of disease after exposure to abiraterone. If they have HRR mutations, they'll be randomized to treatment with talazoparib versus talazoparib and enzalutamide to try to understand if that prior exposure affects anything. Maybe they can just take a PARP. Maybe there's some sort of synergy where a PARP and an ARPI in that context could be helpful. And so if you're thinking about this, if you have patients, that should be open, hopefully at centers around the country and perhaps a few sites internationally, maybe somewhere near you. So think about that for the future. And fantastic run through a million things there, Sandy. So thank you for laying all that down for us. So I think we have a lot of questions pouring in. All right. So we have heard about many options here. I think one of the pressing questions has been, if you have a patient who's progressed on ADT, docetaxel, and an AR pathway inhibitor as a triplet, do you have a go-to option at that time? What are you thinking about in terms of treatments, Matthew?
Sure. So, a patient like that would be eligible for PSMA lutetium based on the current label. Typically, you're choosing triplet therapy for patients with poor prognosis disease, and they're often going to progress despite that intensive therapy relatively soon. But in the occasional patient who had completed their docetaxel long ago, I would be inclined to re-challenge them with docetaxel. That's a nice situation if you find yourself in that. But certainly if they progress, in a matter of months or so after their completion of chemotherapy, I would discontinue the ARPI and then treat them with either cabazitaxel or with PSMA lutetium. If they haven't already had tumor genetic testing and germline genetic testing, that should be performed before you finalize that decision.
Okay, great. Thank you for that. And Sandy, if you have a patient who's been treated before with radium, would you consider treating them with something like PSMA 617, the lutetium PSMA 617 agent, Pluvicto? Or do you worry about cytopenias with prior exposure to radium or other radiopharmaceuticals? Is this something that's safe?
Yeah, I think the goal really is to give every one of our patient all the life-prolonging therapies that we have. So I do like the idea if somebody's just got like 2 bone mets, why not reserve lutetium and try radium? And I think there is data that supports the safety of this sequence of doing radium first followed by PSMA lutetium. So I think I would definitely not hesitate for that patient, especially if they have a PSMA that has a positive uptake, for them to have the sequence of radium followed by lutetium.
Great, thank you. So this is a question that's sort of outlined on our slides, but also came in. Matthew, bone protective agents were discussed. Sandy talked about that. Is this something that we're doing perfectly in practice? Is there room for improvement when it comes to bone health agents?
So we're absolutely not doing it perfectly in practice. That's for sure. The drugs are generally underutilized in some settings and probably overutilized in others. We don't know the optimal dose and schedule. The sort of, for patients with bone metastases, particularly those with progression, the dominant driver of risk for skeletal morbidity are disease-related complications. For those with few or no bone metastases, the risk is primarily osteoporotic fractures. And the therapeutic interventions for those 2 situations are different, right? You need, some cases, the same drug, but at a higher dose and schedule. And then candidly, like a lot of the data supporting use of denosumab and zoledronic acid, were done at a time where we had relatively ineffective systemic treatment. So as I like to remind people, the best way to prevent disease-related skeletal morbidity is to control the disease. So the priority is always going to be their anti-neoplastic therapy. Don't conflate bone protective agents with anti-neoplastic therapy. They have an ancillary role. I tend to use those drugs at a less frequent schedule. It's a rare patient where I'm giving denosumab 120 milligrams every month. It's more like, I line it up with their leuprolide injection, sometimes as infrequently as twice a year, particularly if their disease is well controlled with their current systemic therapy.
Thank you. All right, Sandy, I have a question for you about pill burden. When we're talking specifically about the PARP inhibitor, AR pathway inhibitor combinations, there can be, many pills, especially if we're talking about an abiraterone combination, which also comes with prednisone. Do you find that this is a challenge for patients? This is different for the niraparib abiraterone combination. That's something that makes it a little unique. But is pill burden something you think about? Is it something your patients ask about or share with you as an issue?
Yeah, I think definitely it is an issue, not just in terms, I think pill burden, you think about it as just the annoyance of having to take multiple drugs. In addition to most of them have hypertension, they probably have a little bit of a diabetes. In addition to all their other meds that they're on. But I think the financial burden is so real. I can tell you the amount of time our staff help us, right? All of us, I'm sure, in our practice, trying to get authorization for these patients. Depending on the time of the year, their co-payment varies so much. So I think the pill, it's not just the pill count, but I think there's also a big financial burden that is really has implications for them.
Thank you for that. Matthew, if you're thinking about, or when you consider PARP inhibitor combinations versus a single agent PARP inhibitor, how do you choose the patient? What do you think about there?
Yeah, so we hope that there are fewer patients who are developing MCRPC having not been exposed to an ARPI. And I think, the other issue to think about this is, who are those patients? They either have milder disease such that someone decided they didn't need to intensify their systemic treatment. Should be a pretty small group of patients, right? And they're least likely to progress, to more serious disease with MCRPC. They're older, frailer patients who have medical comorbidities that would reduce the chance that they'll be prescribed those drugs. They have poor access to medical care, they're getting bad advice, or they have bad insurance, or some combination of all those things. So those aren't the patients who you're going to think are then going to get, an ARPI and a PARP inhibitor and genetic testing when they progress to MCRPC, unless they change their location of their of where they're receiving care, or get better insurance or whatever. But so there is a little bit of a conundrum, right? So I think it's an increasingly uncommon patient, at least in my practice, who hasn't had an ARPI, they have MCRPC, and they're biomarker positive. But if they're referred from elsewhere and that's where we find them, then you have to make the proximal decision, in part, is like, which ARPI do you want to give? There are going to be some reasons to choose among those for other medical comorbidities that we already discussed. And then, which data do you find the most compelling? So, those are the practical considerations. And then, it's always about benefit risk, right? And so I think the data for biomarker positive, particular those with BRCA mutations, is very compelling. And I think that should be a high priority to get both drugs concurrently, not sequentially.
Thank you for that. Sandy, double question, 2 parts. How do you think about docetaxel eligibility, and how do you choose between AR pathway inhibitors?
So docetaxel eligibility for me would be frailty. Is the patient, what type of support do they have at home? Who are they living with? What is the help that they have? What I think really performance status comorbidities, number one. And then I think you think about the distance where they live, transportation issues, who's helping them at home. I think all of these things become real because it is a challenge for them to come in, spend an hour at the infusion center, all the side effects. In terms of the ARPI question, I think the presentation yesterday was helpful. I think we have a choice between all of these ARPIs, but I think I found the data about patients who are older, that maybe the amides are somewhat easier. So I think it's nice that you have a choice. You can pick now based on, risk of seizures, whether they have other issues. But I think maybe I will be a little bit more selective about choosing one of the ARPI inhibitors as opposed to ABI for that much older and frail patient.
Great. Thank you for that. And thank you for tying in GU ASCO data. Very exciting. Matthew, when you think about PARP inhibitors again and patients for that, does it matter to you whether the patient's homozygous or heterozygous? Does that make a difference?
I think it depends how it's measured, right? So I think it depends on the assay, and I'm not the ideal person to address the subtleties of that. So for me, at a high level, it's going to be like which gene, because BRCA2 is not ATM. Like, they're very different in their, predicting benefit from a PARP inhibitor. And then, germline, yes or no. So like, germline BRCA2 mutation, you kind of have your answer. They almost uniformly have lost the other allele, either by deletion or mutation. So not so much. I think we all struggle with like the so-called, what I'll call lesser mutations, non-BRCA mutations, as whether or not they're predictive. Because even in the very nicely done, gene by gene analyses from these large studies, they become pretty small buckets very quickly. And so we're just not that sure. I'm very confident that patients with BRCA mutations, it's a driver mutation, not so sure about certain other mutations. And then that will impact the priority in which I use those therapies. I do not give, combination ARPI PARP to someone with an ATM mutation. May not ever give them a PARP, but if I do, it's going to be, after they've had other lines of therapy and sort of run out of other options.
Yeah, great. Great. Thank you for that. And I think it's important to remember in the studies, because these are complicated questions. Thank you for sending them. In the studies, that you actually only needed to have one mutation. So you didn't need to have multiple. You didn't need to have the double hit. So I think that's also helpful as we're thinking about clinical practice. But remembering that these lesser mutations or other HR mutations beyond BRCA are not necessarily going to be all created equal when it comes to sensitivity to PARP inhibitors is really, really important. Just to remind that ZERO, the patient advocacy organization, has participated in supporting this event, and we appreciate that. It is something that they want everyone here to know, that they do have a program called ZERO 360, which provides guidance and counseling for patients to get financial assistance and other support, whether it's support groups, mentor, even caregiver support through their program. And they actually have a toll-free number for patients to call to talk through their financial challenges, which I think in the U.S. at least can be very, very just very important and something that causes a lot of stress for them, but lots of opportunities for support through this program that they have here. Thank you so much for being here. Thank you for joining us online. We appreciate your time. Thanks, everybody.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is developed with our educational partner, ZERO Prostate Cancer. This activity is supported by educational grants from Astellas and Pfizer Incorporated, Bayer HealthCare Pharmaceuticals Incorporated, Janssen Biotech Incorporated, administered by Janssen Scientific Affairs LLC, which are both Johnson & Johnson companies, and Novartis Pharmaceuticals Corporation. To access all materials for this activity, visit peerview.com/WQG860.